Super. Now we are going into the last part, molecular testing in colorectal cancer. Imagine learning our medicine started with this, and now we are having this. Without molecular classification or molecular findings, pathology is incomplete because it has direct effect on the patient. Again and again, you have to remember, if there is a molecular event that doesn't have an effect on the patient, don't read about it. Okay, or keep it in less priority, because we are getting more and more of molecular markers that are having acting as a target for the treatment. Okay, so colon cancer is predominantly sporadic and 10 to 30% with familial risk. Lynch syndrome is up to 2 to 3%. This is the breakage of colon cancers. So molecularly, there are, you all know the tumor cancer genomic atlas, and they divided them into consensus system type 1, type 2, type 3, type 4, and mixed features. But the most used current system is the modified JAS system. Colon cancer can have conventional pathway, serrated pathway, or Lynch pathway. So there are 5 types: conventional FAP, conventional sporadic, serrated traditional, serrated sessile, and Lynch syndrome. How will you know this cancer belongs to this group? You have to look for CpG island methylation and microsatellite instability. When there is no CpG island hypermethylation, then it is a conventional pathway. Then you have to see whether there is germline APC. When there is germline APC, then it is familial. When it is somatic APC, what do you understand by somatic and germline? In somatic, you see the genetic alteration only in the tumor. And this is very, very important point you have to remember. Whenever you are doing molecular workup, you have to look it into the tumor and normal tissue, either from the normal colonic mucosa or even normal blood from the patient. When the mutation is present both in the tumor and the non-tumor normal areas, then it is known as germline mutation. It is present in the germ, in the whole patient. Whereas when the mutation is present in the tumor, not in the non-tumor normal area, then it is called as somatic mutation. Coming to traditional serrated, it is usually associated with the KRAS or BRAF mutation, and it is microsatellite stable. And this tells you what is the percentage of tumors in this type. And in Lynch syndrome, what happens? That is microsatellite unstable, MSI high. And when the MSI is high, you have to check the germline. When there is germline mismatch repair gene alteration, then you call it Lynch. When it is there only in the tumor, not in the germline, then we call it as Lynch-like. That we will see it just in 1 minute. So this cartoon gives you very nice idea about molecular classification of the tumor, CA colon. And this is in the table form, 5 types. And what is the methylation status, microsatellite status, BRAF mutation, KRAS mutation, genus mutation, and what is the histology and what is the location. Most of the genetically or mutationally or molecularly driven tumors are more on the right side. And that's why people are now looking. There is a difference between the right colon and left colon. I think right colon is developed from mid-gut and left colon is derived from hind-gut, I think. My embryology is very poor, but there is some differences. People are looking into it to find out, is there any diagnostic, prognostic, or theranostic role in the right and left side of the colon. So why we have to do molecular? To prognostic implicate, to predict the response to certain treatments, and importantly to provide a framework for screening for Lynch syndrome. Why we are more concerned with the Lynch syndrome, I will tell you in a minute. Prognostic implication, this table tells you very nicely. Sporadic MMR deficient type 1, very good prognosis. Whereas type 2 colorectal cancer with the BRAF mutation, MS stable and methylation positive, okay, type 2, that has a worse prognosis. So all these 5 types, prognosis is very, very significantly different. That's why we have to know the molecular classification. So what are all the molecular tests you will do? What is the helpful thing at the diagnosis and at the progression? KRAS or NRAS, BRAF 600E, MSI status, where we do MLH1, PMS2, MSH2, MSH6, NTRK fusion, and HER2. These are all the 5 markers you have to do. And this talks about molecular. For KRAS, you have to do PCR or NGS. For BRAF and ML microsatellite, you can do IHC. NTRK and HER2 also, you can do either IHC or NGS or FISH. You see NGS in all of them. So I will directly, nowadays, I'm going for NGS. So by doing that, we will get more and more markers, which are other actionable markers. And what are the things that are progression? It's a MSI high or dMMR. Either it can be done by PCR or MSI testing. And this table is very, very important. And there is a purpose for that. A lot of medicines depends upon whether they are positive or negative. And I'm not going to twist my tongue by reading the names of these medicines. How much molecular? People used to call me, how much molecular we have to know? See, we are not a molecular genetic people. We are pathology. Our thing is mainly morphology. But molecular also, you have to know. How much you have to know? For example, you are buying a car. How much you have to know about the car? Just to drive the car, you must know where is the brake, where is the accelerator, where is the clutch, where is the gear, where to put the diesel, where to put the water for the wiper. And when there is a puncture in the tire, how to remove it. These are all the things you have to know. You should not be knowing about how to open the engine, how to clean the engine, and that are not necessary. We have people to do that. So this is the nice example I tell my PGs. If you want to drive a car, how much you have to know? That much molecular you have to know in pathology. And whenever it is indicated, we will go in depth. Otherwise, it is humanly not possible to remember very positive things. Lastly, I want to touch about Lynch syndrome. By definition, it is a germline mutation. Please remember, it is not somatic. Germline mutation of this DNA mismatch repair. MMR means mismatch repair. And we have 4 partners, MLH1, MSH2, MSH6, and PMS2. The brackets are given what are the incidents in the Lynch syndrome. Or deletion in EpCAM or TSES-TD1. This is as a result of epigenetic silencing of this MSH2. Hypermethylation, okay, happens in MSH2 that causes deletion in EpCAM. This is the definition. Please remember germline mutation, and there are 4 members in the MMR. Why we have to know Lynch syndrome? Remember, I told you, in addition to colon cancer, they have risk of a lot of other cancers. For example, endometrium, stomach, ovary, hepatobiliary, urinary tract. There are other syndromes. So we have to screen the patient. You have to screen the family, not only for colorectal cancer, but also for other cancers. That's why Lynch syndrome is very, very important. And what are the criteria for screening the patients? Previously, we used to have Bethesda guidelines. Who are all the patients to be treated, screened for Lynch syndrome in case of colon cancer? But now we follow the universal screening of all patients with the CRC. Any patient with colorectal cancer, we have to screen them for Lynch syndrome, and it is endorsed by many of the very well-known communities in molecular and pathological and clinical. So what are the goals? Identify MSH tumors, separate out sporadic MSH tumors, identify patients that need germline testing, and then family members you have to identify, and you have to screen them lifelong for the tumors of the colon and other organs. So when do you call Lynch syndrome? Loss of immunohistochemistry. This slide talks about immunohistochemistry. Remember, there are 4 members. All of them should be lost by immunohistochemistry. Okay, so this is a negative immunohistochemistry that makes positive. All antibodies, 4 antibodies should be negative. If you see more than 10% of tumor nuclei demonstrating the expression, then it is preserved. There is no Lynch syndrome. If less than 10% of tumor is there, then it is equivocal. If less than 10% of tumor are positive for these markers, repeat the stain or do PCR. And you must see complete lack of staining to call loss of expression. This picture tells you very nicely here, total preservation. Here, totally negative. Only the lymphocytes in the background, they are positive. Here, it is less than, more than 10%, it is preserved, and less than 10% equivocal. You have to go for PCR here. So this is what you have to see in Lynch syndrome. Total loss of all 4 proteins. I told you all 4 proteins has to be negative, and these are the 4 members. In the members, they are grouped into 2. MSH2 and MSH6, they are one group, and MLH1 and PMS2, they are one group, and one of the member is obligate. For example, MSH2 is a must. If MSH2 is lost, you cannot see MSH6. But you can see only the loss of secondary member. MSH2 can be present, whereas MSH6 can be absent. Please remember, when the obligate member is negative, the secondary member will be negative, and it is not otherwise. When the secondary member is negative, not necessarily the obligate member will be negative. This is what this table is saying. For example, MSH2 and MSH6, when all 4 are present, it is sporadic. When MSH2 and MSH6, where is it? MSH2 and MSH6, both are negative. It is again MSS high. It is germline mutation of MSH2. And there can be loss of only MSH6, and here there is germline mutation of the MSH6 gene. Okay, so there are 4 possibilities. To call it as Lynch syndrome, all the 4 should be lost. You have to keep it in mind. So this is a flow table. Just I want you to take a snap. Remember, there are 4 members. Screen the patient, do MMR IHC. When all 4 are preserved, no further testing. When there is loss of MSH2 and MSH6, refer for genetic counseling for MMR gene germline mutation or EPCOM mutation. When there is loss of MLH1 and PMS2, then we have to do for BRAF mutation. Because when remember, BRAF mutation can happen in MMR unstable. In those cases, we have BRAF positive, and again, when BRAF is positive, we have to see whether it is hypermethylated or non-hypermethylated. When it is positive for promoter hypermethylation, no further testing. When it is negative for hypermethylation, we have to go for germline mutation for Lynch syndrome gene. So please take this table also a snapshot. Just go through, compare this with the flow chart. Remember, there are 3 pathways: sporadic conventional pathway, serrated pathway, and Lynch syndrome. Take that protocol and keep this protocol next to each other, then it will make a lot of sense. So when do you call Lynch-like syndrome? So it can be an incorrect MMR IHC result, it can be biallelic somatic MMR gene alteration, or it is germline mutation present, not detected with the current methods. Okay, so these are all the 3 possibilities for Lynch-like syndrome. And as you remember, the mismatch repair gene can have sessile pathway associated with the BRAF mutation, adenoma pathway with somatic only Lynch syndrome like features, and Lynch syndrome itself with a germline mutation. There are some tumors that are showing BRAF positive, and they are without microsatellite instability, and they are very aggressive tumor, and triple therapy may be useful in that. And it's better to do NGS in all colonic cancer tumors whenever the patient can afford for it, to look for additional actionable markers. And that's how they came up with the POLE, polymerase epsilon, by doing NGS. So it can be epsilon, can be the POLE can be low, intermediate, or high, depending upon the mutation load. Lastly, PD-L1, as I told you, what happens? The tumor cells, through the PD-1 and PD-L1, they make the T cell silent. So you remove that, and then the T cells become active and they kill the tumor cell. That's where the anti-PD-1 and anti-PD-L1 will help. So this is the cartoon that tells you the importance of thing. And please remember, wherever there is an increased number of T lymphocytes or lymphocytes infiltrating the tumor, chances are high where the PD-1 and PD-L1 treatment will be effective. And this picture nicely shows you how to apply molecular pathology for the treatment. And the only thing I want you to remember is right side is different from left side. There are some treatments which is common to both right side and left side. Some treatments that are working mainly on the right side, some treatment mainly working on the left side. For example, HER2/neu works mainly on the left side. And this is the final slide. This is the future. Whenever a patient comes, it's a treatment team made up of pathologists, molecular biologists, surgical and medical oncologists. And role of pathology is very, very important. Screening, diagnostic tests, high throughput molecular and computational testing, and maintaining the quality control in all of them, and biobanking the tissue. And then demographic data and research also done by pathology and clinicians. So all the inputs are put for the treatment team in selecting the treatment of the patient. Please remember, patient is our boss. We have to treat him very well. You have to keep the boss happy and healthy, then only we can survive. So coming to the conclusion. So we talked about WHO 2019 classification, challenges in CRC reporting, IHC in CRC, molecular testing in CRC, and Lynch syndrome. What you have to know in WHO, there are 10 types morphologically, microscopically. The challenges are gross and total mesorectal excision. How do you gross it? What is the difference between radial margin and radial surface where there is serosal involvement? What are the challenges in lymph node, and what is the risk stratification stage? For example, venous invasion and perineural invasion, tumor budding, tumor deposits, they all come under risk stratification. What is the IHC markers? CK20, CDX2, and SATB2. Again, they are helpful only in the metastatic setup. What is the molecular testing you will do? KRAS and NRAS, BRAF, MSIH or DMMR by doing IHC for all the 4 markers, NTRK fusion and HER2/neu. At the progression now is DMMR and other actionable markers in NGS. And then Lynch syndrome, there are 4 members, and to call it as a Lynch syndrome, you must have the germline mutation in all of them or in 2 of them in the obligate genes. Okay, this brings to the end of our discussion. And these are all the articles, references. And this is a nice article in May 2021, very current. The second article is from July by Heather Dawson. And Raul Gonzalez, many of you who are following him in Twitter or Facebook or YouTube maybe know him. He's a wonderful speaker, wonderful gastrointestinal pathologist from Boston. And the third paper is from Histopathology 2020. And Rahul Gonzalez has a very nice Pathcast video. I don't know how many of you know Pathcast, Pathology Cast or Pathcast video. And he has a talk for 1 hour under the heading Challenges and Gray Areas in Evaluating and Staging Colorectal Carcinomas. Most of the stuff I put as challenges in CRC reporting are from this talk. So I kindly request all of you to listen to this.